Welcome to HMA's Vital Viewpoints on Healthcare, where we have concise conversations with experts to explore practical solutions for improving healthcare and human services. I'm your host, Jen Colmonico, and today we are tackling a vital topic: waste, fraud, and abuse in healthcare funding. This is something we hear a lot about. We certainly hear a lot about during campaign season, and it has some real implications for healthcare resources as well as the quality of care. So we're thrilled to have an expert with us on this topic. Let's dive in. Today, we have the opportunity to talk with Jen Bridgeforth. Jen is an accomplished healthcare executive with over 17 years of experience in claims, billing, compliance, and fraud prevention. Jen has worked across Medicare, Medicaid, managed care, and behavioral health, helping organizations navigate regulatory complexities while advancing health equity and community care strategies. In her work, she's also focusing on critical issues like the opioid public health emergency and supporting rural healthcare systems. She's currently pursuing her doctorate, exploring the impact of parental opioid abuse on children, showcasing her passion for creating meaningful change in healthcare. Jen, I'm excited to have you with us today, not only because this is a discussion among two Jens, which doesn't always happen, but because we have been following your work and the contribution that you're making here at HMA. So we're really just excited to talk to you. So thanks for being here.
Oh, yes. Thank you for having me. Super excited to be here and discuss this topic.
Waste, fraud, and abuse is a very common phrase. We hear it from politicians. We hear it on the campaign trail, and it's a real concern. We hear stories in the paper of big settlements with fraud, and so I guess as you think about your work over all of these years, help us kind of parse out the reality, kind of what's the reality and what's the rhetoric. You hear waste, fraud, and abuse, and you think, well, of course we want to get rid of that, but it's more complicated than that. So, talk about your perspectives on how this issue really is pernicious within healthcare spending.
Sure. So I think one of the first things I would like to discuss is just really providing context to, what regulatory agencies actually mean when they say fraud, waste, and abuse. So you often hear those terms, and you might often hear them say, be called FWA, but essentially, fraud is an intentional action to obtain payment, and you've somehow misrepresented the facts, and then attempted to be paid for that service. And then waste is more of unnecessary cost to health insurance programs. And then abuses, it includes all practice areas, and it's not necessarily fraudulent, but it still will result in improper payments. And I think throughout that process, over the years, I've learned that, physicians often struggle to understand where the responsibility falls for, medical coding and billing. Often when we used to open up investigations, they'd say, well, I have staff to do that. And I do feel like throughout the time that I've done investigations, physicians don't often understand that the responsibility ultimately lies with them, because their name is the one that is on the claim and goes out to the health plan to be paid. And so I think more so than anything, there is a lack of understanding related to billing and coding. However, I do think it's important that everyone knows that the physician's main focus is always to be patient care. That's where their focus should always lie. Although there is some responsibility related to medical billing and coding.
So they're accountable for that bill that gets submitted, but their focus is on the patient care, and so there's almost always somebody else who's entering the code and applying the details on their behalf. So is it sort of they're accountable, but they're accountable for a team effort?
So they are accountable. There's always going to be a medical coder. And then um, with technological advances, there are system edits that are in place and templates to help that charge be entered into the system and sent to the health plan. But ultimately, at the end of the day, if there is an issue with that claim, that physician will be the one that is held accountable. However, there are instances where the physician and his medical coder have also been held responsible for the claims that were submitted. You will often see releases in the news, like press releases from the OIG and the Department of Justice. And if you look very closely, you will see that the healthcare provider and their staff members have been actually held accountable as well. So,
Mm,
although the physician, his name is on the claim, he will be held responsible for that. Staff members can be held accountable too if they have taken part in the fraudulent behavior.
right. So I appreciate you parsing that out and defining those three because that, too often it's jumbled together. So they really, really are distinct. Um, let's talk about sort of the waste part, because that it's not intentional action, it's not intentional waste. One of my mentors always would say, one man's waste is another man's income. So how do we think about waste, which is really probably the political issue in an environment where they're looking to cut, quote, unnecessary spending? They're going to look there. In your experience, how much waste is really waste, and how much of it is just sort of different ways of doing things?
Sure. I do think there is a certain amount of waste in healthcare. And I think just to put it in more simpler terms, so waste, that would be things such as unnecessary tests. So if you go to the doctor and you've already been diagnosed with a condition, but that same doctor orders that test again as a way to confirm that you have that condition, that's an unnecessary test that you did not need to have, which results in unnecessary spend to your insurance provider. And that insurance provider, it could be, we hear a lot about Medicare and Medicaid, but truly those issues can exist within any health plan. And being a healthcare executive, I have responsibilities related to revenue integrity. And we would often see, there were times where a provider would provide services. We would request the medical records, and we truly could not see where that service was medically necessary for that beneficiary. And in turn, that would result in, an overpayment to that provider.
Yeah, so that's interesting because what would drive to retest, right? Sometimes it's to be able to prescribe a medication or, something that might have been well intentioned on the part of the doctor, but because of our kind of fractured system and requirements and pre-authorizations, things don't always line up, right? You look at it realistically, it wasn't really necessary, but maybe you needed to check that box in order to check the next box, which, is I feel like part of what we're talking about when we're trying to simplify and standardize and
Yes, yes.
are you seeing less of that over time? Are we getting better at this?
We are getting better, but I think ultimately it goes back to documentation. And something that we used to say all of the time is that if it isn't documented, it didn't happen. And I think a lot of the time there might be a legitimate reason for the service. However, the service provider did not document it in a way that it is shown in that patient's medical record. And I've even had discussions with providers, and they're like, well, I know this patient. I have a very close relationship with this patient. We did this because of X, Y, and Z. The problem is, though, it's not in the medical record, and it's not enough to verbalize something. You have to write it down because the physician, more than likely, they're going to be expected to provide records generally within 30 days, and you can ask for an extension of 15 days. So I think Medicare and other payers, they've improved providers' ability to obtain information on what is required. But I do think there's still an absence of physicians having the tools that they need as far as, their system working for them, their EHR, their electronic health record. there's more work needed there, but I do think there are technological advances that exist today. I think people are creating them in the hopes that it will help physicians and make the documentation process easier so that we can ensure that they are paid for the hard work that they do.
Sure. Yeah, I mean, electronic medical records are in essence supposed to simplify that. Do you think that they have?
In some ways, yes. However, I do still think there is work to do. I feel like artificial intelligence is on the rise and truly a way for providers to be helped and assisted throughout the documentation process. But I do feel like there's more work to be done. But truly, there are some amazing EHRs out there. Um, they've worked to help truly help providers in the documentation process. Some are better than others. However, I do think there are companies that are making uh, providers a priority and really listening to them, and even doing like focus groups and surveys as they build out software to ensure that the software is meeting the needs of the audience. I think oftentimes companies can, they'll push a product to market in EHR, and then it'll suddenly have a ton of patches because the end user is unhappy with it and it doesn't suit their needs. But I think as time has gone on, technology companies are truly engaging providers to say, hey, does this work for you and will this work for you? And having kind of soft launches so that providers can test and provide real-time feedback before it's actually released for everyone to use.
That's really optimistic. I mean, EHRs, I think, were intended for this purpose, but they probably really weren't designed with physicians in mind, right? They were kind of effectively billing tools. So the innovation in that space, as you describe, is, hopefully going to get us to a better place, at least in terms of that need for documentation. What are some examples of waste? I guess maybe what are the most common examples? You talked about unnecessary tests, but are there huge sums of money out there to be saved if we could only figure out this one thing? What's your sense of that?
I do think right now, the government, they estimate, hundreds of millions of dollars that are lost from fraud, waste, and abuse. And you'll hear those dollars provided collectively, not necessarily like, oh, waste is this amount. That's generally not how they report it out. I do think there are ways for us to mitigate that, but I don't know that we always tell providers how they can mitigate fraud, waste, and abuse. And specifically waste, I think that sometimes is like a gray area,
Mm,
because what one defines as waste truly might not be what someone else does. I think for fraud, just for me being a fraud investigator, you can often see the intention there. A provider, billing for a surgery that, a patient has already had and things like that. And then sometimes you will find that uh, an action taken by a provider, whether it's a hospital, physician, a nurse practitioner, you will find that that action falls in multiple categories. It's not just fraud, it's not just waste, and it could also be abuse. I think it's hard for providers to really understand what the action they're taking in their day to day. Is this fraud? Is this waste? Is this abuse? Because they don't believe that it shows intent. And so, really, it's like, well, I didn't sit down at my desk on a Monday morning and decide to commit fraud. But then, they'll go through, the record request process and, the appeals process, and then that final process, which is generally the administrative law judge, and they've deemed all of the services included in that medical record request as exhibiting fraud, waste, and abuse. So I think there's a certain point where some would view fraud, waste, and abuse as subjective. However, it's the job of Medicare, Medicaid, and then the administrative law judge to really make a determination so that it really truly is something that is deemed objective, and it will often result in an overpayment.
So the fraud part seems to be uh really the bulk of it. I mean, if or is that what you're saying in terms of the dollars saved when they're projecting it is it's really the fraud that's causing that loss of revenue or loss of dollars?
I do. I think that. And then you like when you hear about it in the news, it's a discussion about fraud. You don't hear a ton about waste. You don't hear a ton about abuse. There's the focus on the fraud that is occurring. And I think when people hear that word, they think, oh my gosh, this is so awful. And granted, there's nothing good about fraud occurring in the Medicare and Medicaid program. It is absolutely not. However, I do think people need to understand that fraud it doesn't matter if there was any type of intent there. If the fraud occurs, it will result in an overpayment. And I think when legislative agencies have these talks, specifically CMS and the OIG, there is a huge focus on fraud. Um, and not necessarily the others. Not saying that they aren't out there and they aren't occurring, but what makes the news is fraud.
Yeah. So the part about the waste, is that more political rhetoric versus the reality?
It's hard. It's really hard to gauge. I do think there's some political rhetoric there. I do think it is happening, and I do think it is important from a compliance perspective. But I think when legislative agencies and regulatory bodies are having these discussions, such as, the OIG, there is a lot of focus on fraud. If you were to go out and search right now, and Google anything from the OIG, generally you will see these enforcement agencies focus largely on fraud, or you will see the word quote scheme when they are discussing anything related to a compliance issue from a provider. So I think for me, if you're reading the news and you hear the word waste, are you really going to pay attention? Probably not as much. But if you see the word fraud, and you see that word fraud with scheme, you might perk up a little bit and read, focus a little bit in on that story and what is there. So I think it really is the word fraud is it's an attention grabber. It makes the reader want to keep going, whereas waste and abuse, maybe not so much.
Yeah, I think waste is an interesting word because I feel like there's, baked into the American psyche is this kind of assumption that government is inefficient and this assumption that things are wasteful. It's sort of this broad brushstroke, accusation that can be painted on both sides from any direction. And people just kind of nod their heads, but it's not necessarily particularly meaningful. It's a general assertion. Whereas fraud, it's like, oh, there's a bad guy doing a bad thing, or, bad woman, bad person, whatever it is, doing a bad thing, clear, good guys, bad guys. We get that, right? It kind of fits into that
Yes.
that rhetoric. But the waste is, I think it serves a different purpose, which is why I'm always, kind of interested when you roll it together and then somebody says we're going to tackle this. Well, then what does that mean? So then
Yes.
what is our action? Is it more ironically more government, like OIG, staffing up the OIG, staffing up the enforcement agencies? That's more spending, but arguably, to find the bad guys. So, we can maybe get behind that. How do we tackle waste at a broad level?
So you raise very good points. Everything that you said, I completely agree with, and I think it's valid to question, waste and where does it fit in the grand scheme of things, because it's one of those things where I don't feel like as the public we hear that word waste, but really what does that mean for health insurers? And I think we definitely overall, I think there is some more work to do because I do think waste occurs. It's just not at the forefront for me. I feel like when you hear about it, I don't feel like, again, regulatory bodies are focused on that. Now, I think when consumers, like you or myself, we hear about waste, I think it might be a little bit different. Maybe the implications are different for us, but I think for regulatory agencies and even for, you know, national bodies, the focus is on the fraud and it's not on the waste. And I don't have all of the answers, but I think that um, we're going to see probably more focus there. There is now that we have a new administration, maybe there will be a different focus on, the waste and the abuse and less on the fraud. But I think that if you were to go out and look now, there's going to be a lot of focus on fraud and the words fraud scheme. And that has traditionally been the focus. And unfortunately, I don't know what it will take for that focus to change. I'm not sure.
Yeah, it's less, you're right. Fraud has a starting and end point, and you can say check, mission accomplished, right? Whereas waste is complicated. Healthcare is complicated.
Yes.
And so, when we think about all of the ways in which we're trying to reduce waste, what is it that patients need to get healthier more quickly, right? And is it more tests? Is it, other interventions that frankly maybe cost more money but are maybe more effective?
Yeah.
People aren't all the same, so it's tough to crack that.
I agree. And I think as we focus more on value-based payments and not like so right now, traditionally the way that providers are paid is the more you build this code, the more you're paid. But I think as we see a shift into value-based payments, I think that that is going to decrease FWA in general. Fraud, waste, and abuse will hopefully go down when you start rewarding providers for, hey, we're going to pay you, based upon the health of your patients, right? And so I think when you have, when you add the value-based payment piece, that can truly help with healthcare expenditures overall and not just decrease the fraud, waste, and abuse. Because when you tell someone, hey, if you build this code 10 times, you're going to be paid this amount, it may be a small percentage of providers that might decide that it's worth the risk to overbill for those services, overcode for those services, overutilize those codes because it results in higher payments. I'm looking forward to seeing CMS coming up with more value-based initiatives and, managed care organizations coming up with more value-based solutions so that really the patient is the forefront. The patient is the center. There has to be some focus on reimbursement, but move toward that patient-centered care and truly reward providers for having healthy patients, and prevention. And I think in value-based care, there's a huge opportunity for prevention and for there to be focus on prevention as it relates to taking a more holistic approach to healthcare.
Yeah, that's so important. And we've been talking, there's been a value-based care conversation in healthcare for a very long time, and yet and we've made considerable progress, and yet not enough, right? We haven't gotten past the hump of sort of being the majority of payments. From your point of view, in the clinical settings you've worked in, what do you think is the biggest obstacle? I mean, is it the physician resistance? Is it the infrastructure? Where why haven't we moved faster when those outcomes, I think everybody could agree, are good, right? So why haven't we moved faster to changing how we pay for things?
So, I think change is hard for any industry. And when you've been doing something the same way for so long, it's really hard to shift. One of my closest friends is a nurse practitioner, and just having we have a lot of discussions about health insurance and reimbursement and things like that. And I think one of her concerns, and this truly allowed me to see it from a provider perspective. And she said that when you think about value-based payment and you look at your contract as a provider and you see that you are going to be rewarded for patient outcomes. She said it could be a way for providers to essentially move away from assisting the patients that A might be resistant to, certain care modalities, and B, they might be just resistant to care in general, so that care continues to decline, which essentially makes that provider's quality scores go down because they aren't meeting those marks that the health insurance has placed in their contract for them to receive, those quality incentive payments. So, that's really a different perspective. And I think there might be some resistance from providers because of that, because for quality incentive payments, some of it is based upon patient behaviors, beneficiary behaviors. If they're not, really working with the provider to ensure that they receive proper care, because I mean, honestly, I've been one of those patients before, being diagnosed with a chronic illness early on. I was more concerned about, being in college versus going to the doctor and continuing care. And so even with elderly patients, they might be a little bit resistant to, hearing that they have to change eating habits and things like that, which all of that can impact quality incentive payments. And I think a lot of times, there are things put in place in this industry and we don't always think them through. So there might be some resistance from just providers in general. And a lot of provider organizations do come out with their opinions, and they will often, during that public comment period, they will often, reach out to CMS about their concerns. And so CMS will sometimes take those concerns into consideration. And so some of that resistance can come from various parties within the healthcare delivery system, not just providers.
Mm. That's so interesting. And it kind of takes you back to the waste conversation because, if a doctor has a challenging patient, as, they all do, right? Humans are complicated and not everybody follows the rules. And so
Yes.
you have a complicated patient and you're trying to throw a bunch of things at him to try to make him healthier. You have a limited ability to make that patient healthier, depending on the situation. And so in retrospect, somebody might say, well, that's wasteful. You did these things that didn't have a real clear impact. But it's like if you're the doctor, you're trying anything at this point, right? So the risk is not always you're not always able to take that risk with certain patients.
Absolutely. And I think as we continue to have these discussions, we have to really go back to documentation. When providers have patients that are difficult or they have to, complete a test more than once, it is really important to document the reasons why. It is important to document any service that has to be completed more than once. And because what you don't want is for it to look like that service was never rendered, or um, appeared that, this first service wasn't that expensive. So, I want to do a more, expensive test. You never want it to appear that you are upcoding or falsely billing. So at the end of the day, a lot of this goes back to documentation. You
Mm.
have to document it. If it wasn't documented, it did not happen.
Based on your experience and your observation of these different dynamics, if you had a magic wand and you could wield it in any way to improve the circumstances that we're talking about here, how would you wield that wand?
Oh man. So I think for me, the one thing that I would love to do is require some type of intensive coding and billing courses for healthcare providers. Generally, by the time a provider would get to me on the fraud investigation side or on the side where I was attempting to assist them in navigating a medical record request they had received from the Department of Justice or CMS. They weren't informed about documentation and, revenue cycle and things like that. So I would love for providers to be required to, at some point take some type of extensive coding and billing course, revenue cycle management, because generally when you're in medical school, the primary focus is, patient care. So when you have your curriculum, that's the primary focus. But in reality, when you go out into the world, you are going to be responsible for billing and coding of services. And a lot of times, these rules can be complex, and the provider lacks the knowledge on that side because they've spent their time doing what they were supposed to do, which is patient care. So my magic wand would be that there's a requirement for some type of coding and billing and revenue cycle management so that providers are truly well informed and they are informed enough to know the questions to ask someone like me, when they need assistance. Because I truly used to hate, by the time some providers got to me, they had an overpayment from CMS. There was $3 million, or they're on the verge of CMS conducting some type of extrapolation against their claims. And at that point, the provider is frustrated and anxious, and truly trying to figure out how to navigate a system that they haven't been that familiar with in the first place.
Yeah, they're not really trained to be business leaders, but they are, whether they're independent practice or even in a group practice, they have a business responsibility. Uh,
Yes.
and you're right, they're not really well prepared for that. And it's Byzantine and it's complicated. And it's funny when you say like they should have a class on coding and billing. I'm sure every physician just like the hair went up on the back of their
I know.
neck, right? Like that is the last thing a physician wants to do, but that's what they're responsible for as a business owner. So how do you make that?
Yes.
It's a great magic wand, right? Because how do you make that
Yes.
relevant and easy and support them in making better decisions?
Yes, and I have a passion for provider education. It's something that I've done for many, many years. And although I have a passion for provider education, I truly feel like it is something that they should be well versed in prior to them ever speaking to me, because there's always something that caused, a physician practice to seek, me out, or a hospital to seek me out to educate physicians. It's usually that a payer has contacted them and said, you are an outlier among your peers, and quote, you need to shape up. And so they should be well informed before that, not
Yeah.
on the back end, prior to, more proactive instead of reactive.
Yeah. And I guess that goes back to sort of the intentionality, right? I think I conclude from this conversation, fraud, abuse, that's clear cut, good guy, bad guy, go find him, work it out. But really, in terms of, the intentional misbehavior, it is very subjective, and we as a society are not really doing the best job to support physicians in being successful there, in terms of providing them with the information, but also, designing payment systems that are not as onerous. I mean, I'm really glad you brought up value-based care, right? There are a lot of ways we could do it where it wouldn't be as complicated and it might have better outcomes so that, they still need to take up their responsibility to navigate properly, but we could also make it easier for them. So,
Absolutely, can definitely make it easier. And I'm hoping that there is a day where it is easier and it's not so cumbersome for them, because truly I want physicians and, nurse practitioners, all healthcare providers, I want their primary focus to be on patient care. Because at the end of the day, if patient care is a focus and we can improve patient outcomes, then healthcare expenditures will ultimately decrease.
yeah, and we'd all love to be able to see that. So,
Yes.
excellent. Anything else that we didn't talk about that's important for people to understand this issue?
I would like to reiterate, if it is not documented, it did not happen.
I like it. Jen, thank you so much for your time today and for all the work that you do. And we really appreciate you.
Awesome. Thank you so much. And I'm so glad you guys had me on. It was a joy.
This This episode of Vital Viewpoints on Healthcare is sponsored by HMA Information Services. HMAIS is a subscription based service that provides state level data on publicly sponsored programs like Medicaid. From the latest managed care enrollment, market share, and financial performance data to up to date RFP calendars and state by state overviews, HMAIS has all the information you'll need to power your initiatives to success. This podcast was produced by myself, Jennifer Colomonico, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.